who is violently slamming the table with her fist.
Like a prescription.
Why is neurology so unpopular? Once you take someone's socks off and all that dead skin falls all over the place, you know why it's unpopular. That's true because you oftentimes are testing their sensation in their feet, right? Jerry flakes, skin sprinkles, oh my goodness. Sock tarts, forbidden Parmesan, granny glitter. You guys are something else. All right, things I liked about neurology, things I didn't like, and then finally, should you pursue neurology? Starting with my fascination with the brain and nervous system. I find that people either really love the brain because of the complexity, or people really hate the brain because of the complexity. Even before college, I love this stuff. Books like The Man Who Mistook His Wife for a Hat were incredibly fascinating. And even when I was younger, I had books in grade school that were fun to read. Things on biology, specifically the brain, also things like engineering and cars, of course. When I went to college, I got my BS in neuroscience at UCLA, and I always loved learning about the field. Neuroanatomy was actually one of my favorite courses in college, which is strange, right? Because most people don't enjoy memorizing the pathways, but I always found it interesting and highly relevant to how we all function. I was also on the student stroke team at UCLA, where we enrolled stroke patients in a clinical study, and I got to see the stroke team working their magic and even briefly shadowing some more interesting endovascular procedures. The stuff is pretty neat.
Neat.
Even the simple things are really fascinating. When we apply this to our daily lives, it's hard not to be fascinated by it. Something as simple as the reason why we rub our skin after we bump into something and experience that pain. So learning about the pathway of touch sensation and pain, right? And how it goes up to your spinal cord, and in the spinal cord, there's an inhibitory neuron, and when you're rubbing your skin, it decreases the pain signal sent to the brain. Or things like learning about HM and other iconic patients that helped us understand the function of various regions in the brain. This stuff is just super wild. In med school, during your preclinical neurology, you focus a lot on localizing the lesion. So trying to find if there's this deficit or this cluster of symptoms, where is the lesion? In the brainstem, in the spinal cord, etc., etc. We did a little bit of this in college, but it's focused much more heavily in medical school, and I loved it because you're solving this neuroscience puzzle. And it is a very diagnostic heavy specialty. This is actually a big reason why a lot of people are turned off by neurology, because they find the memorization of these various spinal pathways too challenging and cumbersome. But I think if you approach it through the lens of applying it to your real life scenarios, it becomes way more memorable and even interesting. Once I got to my clinical rotations and rotated on neurology, way different than the classroom, but we'll get to that more in a later section. But in even the clinical setting, you do feel like the real life Sherlock Holmes as you go through the physical exam in history. And a lot of people either don't like or don't get or are intimidated by neuroanatomy. I think part of the reason I love it is that I was incredibly fortunate that I was taught by highly renowned teachers, both in college and in medical school, for neuroscience and neurology, which helped build that interest. Number two is the tangibility. When I first got to college, I knew I loved the brain, but I didn't fully understand the difference between neuroscience and psychology or psychiatry. But once I did learn the difference, I appreciated how neuroscience was far more tangible and a much harder science. Now, of course, I still found and still do find many elements of psychiatry and psychology interesting, but the tangibility of neurology and neuroscience just appeals to my personality more. Psych is something that I enjoyed far more in principle and in theory than in practice. Learning about evolutionary psychology and gender dynamics or mature versus immature coping mechanisms, all that super interesting, but psych as a rotation required far too much patience for my personality. It wasn't as fast-paced or concrete enough for my needs. Learning about the psych underpinnings of human behavior is very different from treating a patient who is violently slamming the table with their fist with vitriol and yelling at you, calling you a Hispanic devil. I mean, I'm not even Hispanic.
Like the prescription.
Neurology is a much harder science than psych, and it's a puzzle with a more concrete and definitive endpoint, at least most of the time. You can point to a structure and its lesion, and then understand what the deficits or symptoms would be. Next is the length of training. When you're in medicine, you're normalized to certain specialties being their own residency and other specialties being fellowships after more foundational residency programs. As an example, to do cardiology, you do 3 years of internal medicine residency and then 3 years of a CARDS fellowship. Similar for GI and endocrinology and many other specialties. But if you look at surgical subspecialties, you have a dedicated residency for plastics, orthopedic surgery, neurosurgery, ENT, and so on. But if you go several decades back, they were generally fellowship options after a general surgery residency. Based on this, one could argue it's strange that neurology has its own separate residency program. And that's because, similar to these surgical subspecialties, what neurology did about half a century ago is split off and create their own. The benefit is that it tends to be more focused to your specialty, and it's also shorter, lasting only 4 years. But the trend these days in neurology is to do a fellowship, so the 4 years becomes 5 to 6, which isn't really short anymore. But keep in mind, with a 4-year residency, you're making around $300,000 per year. Most of the other shorter residencies, like internal medicine hospitalist or family medicine, tend to make less money, around $240 to $270K. And sure, emergency medicine makes more, around $350K, but other specialties which are 3 to 4 years in duration usually make less. Also, in neurology, with 1 to 2 year fellowship options, you can make north of $400,000 with paths like neuro ICU, vascular, neurocritical, and interventional pain. Next is flexibility. It tends to be lifestyle friendly with the exception of a few subspecialties like stroke. You can be inpatient, outpatient, or both. If you don't want to deal with inpatient, and there are pros and cons there, then you generally need to do a fellowship. Now, fellowship options, as we just discussed, are going to boost your earnings considerably. Sure, residency is miserable, but as an attending, you can work fewer than 40 hours per week if you want to, and also outpatient only, and no weekends, and no nights if you want to. On a related note, neurology residency is more attainable. It's actually the 6th least competitive specialty, above only PM&R, emergency medicine, psych, peds, and family medicine. If you're a strong student, you get your pick of whatever city or program you want. And when you ask, why is neurology less competitive? 4 reasons come up. The first is neuroanatomy can be a big turnoff for many students. Number 2 is a fair number of schools don't have neurology as a required core rotation, and therefore there's less exposure to the field. Number 3 is the stigma of diagnose and adios, where you as a physician say, can't really help you with that, but we'll get to this later in the video.
Deal with it.
And number 4, the specialty used to have lower compensation, but because of the shortage of neurologists in recent years, compensation has bumped, most recently to about $310,000 per Medscape. And this brings me to the next point, the job prospects. Now first, because it's not a very popular specialty and few US MDs go into it, it makes it a lot easier to get a great job even in a big city. Second, a lot of neurologists are betting, and I think reasonably, that reimbursement will jump over the next 10-ish years as neuro gains more therapeutics and infusions. This is driven in large part by a better understanding of neuroscience. This pattern would actually be similar to what we saw happen with medical oncology in the early 2000s. And third, because there's a great deal we still don't know in neurology and in neuroscience, at least compared to many other fields, we're likely to see rapid progress here compared to other fields in the coming decade and beyond. Now, even in the last few years, there have been many advances with a new class of migraine medications and this incredible gene therapy for spinal muscular atrophy. Next is that the specialty is hands-on. The physical exam for neurology actually counts for a lot, unlike most other specialties. When practicing the physical exam in medical school, I always found the neuro exam and the MSK exam the most fun and helpful clinically. And for those who don't know, MSK stands for musculoskeletal. And last is the broad knowledge. I've always appreciated physicians that have knowledge across many domains rather than having a singular narrow focused. But I always considered myself to be more of a narrow and deep kind of guy rather than broad and shallow. But now, as I'm enjoying learning about the human body through the lens of longevity, exercise physiology, and the interplay between various organ systems, I see and appreciate the utility and enjoyment in connecting different systems rather than having just a narrow focus. And that brings me to today's sponsor, Levels, because a big part of my obsession with longevity and health optimization has been in metabolic fitness. And Levels helps you understand your metabolic fitness and how it connects to various parts of both your body and your life. They provide you with a continuous glucose monitor, or CGM, and equally important, a slick app that helps you visualize your blood sugar and understand what keeps you in a good optimal range and what spikes you. The Levels app is key in allowing you to understand and make sense of the data without being a professional. The key here is that while there are some commonalities between us, I mean, eating a whole bag of Sour Patch Kids will likely spike all of us, there are many differences based on our genetic makeup and gut microbiome. So sweet potatoes might be okay for me and terrible for you, or vice versa. And this app allows you to discover what foods are working for you and which aren't. From a behavioral change perspective, the tight feedback loop, meaning the shorter time period between your input, being your behaviors, and your output, being your blood sugar, allows you to make meaningful change and has been absolutely huge in helping me eat better. I've been motivated to truly prioritize sleep after seeing what sleep deprivation does to my blood sugar levels, as well as the ordering of what foods to eat when I'm at the dinner table. So proteins and fats before carbs works wonders. Back in 2019, I purchased a month of Levels using my own cash, and I loved it so much that I reached out to them to work together, and I've been using a CGM almost daily for the last few years. I find it that valuable. See what the hype is about and try Levels yourself using my special link to get 2 months of free membership linked below. And now, back to the regularly scheduled programming. With neurology, it's important to be well-rounded. If you're covering the neuro ICU, you still need to know diabetes and liver injury just like internists. Neurological conditions can affect all systems, so neurologists tend to have a good understanding of internal medicine, psychiatry, ophthalmology, and musculoskeletal in addition to other areas. Sure, you're not as broad and well-versed as an IM doc, but definitely more so than many other specialties. This actually depends. So let's say you're a neurohospitalist, and depending on the hospital culture, the neurology admitting team can manage a large number of general medical problems. But in other places, the neurologist gives up a lot of that body medicine, meaning those more internal medicine diseases. On to the things I didn't like. The first is the bread and butter. A common mistake I see many medical students make is idolizing a specialty based on the cool, sexy zebras you see in that field, meaning the rare cases, not the bread and butter, meaning the more common presenting cases you'll see day in and day out. Neurology does perhaps have more interesting zebras than other specialties, but again, they're not the norm. If you cannot see yourself dealing with the bread and butter of a certain specialty, then don't do it. And neurology, I couldn't see myself doing the bread and butter. It has a lot of headaches, seizures, strokes, and altered mental status. Of course, there's much more to it, like Parkinson's, dementia, multiple sclerosis, and so on. You will be working with a lot of tech on these diseases, like EMG, ENG, and many more, which is kind of cool, but you'll have to decide how cool that is to you. In inpatient, you'll be dealing with a lot of stroke and seizure, and in outpatient, a lot of headaches and seizure. Multiple sclerosis, movement disorders, Guillain-Barré syndrome, they're more interesting, but not nearly as common. It is nice that there is variety in the acuity. So full-on emergency, like stroke or neuro ICU, and then non-urgent things like dementia or movement disorders. Next up is the theory versus practice debate. There's neurology in medical school, and then there's neurology in real-life medical practice. The biggest issue I have with neurology is that no matter how cool it is in theory, and I mean, I loved learning about the nervous system, the actual practice is, to me, nowhere near as interesting as the theory. One of the realities of medicine as a whole, all specialties, is that the book learning of medicine can be very different than the clinical practice of medicine, and that's both for better and worse. For my taste, neurology is a bit slow and a bit dull. Next up is the residency. It has a reputation of having one of, if not the most difficult non-surgical residency. Oftentimes, you're expected to be an expert on some rare disease that no one's ever heard of based on some obscure imaging finding, but becoming that kind of person has a price in training. You essentially complete 2 intern years, one for IM and one for neurology. PGY2 is known to be particularly brutal, where you're expected to have a great deal of knowledge despite lacking much experience. A big reason why it's considered so challenging is, again, those 2 intern years, plus large census, stroke call, and a very large body of knowledge. Most programs also have limited outpatient rotations, limited electives, not always the nicest people either. There are programs that do night float rather than a frequent 24-hour call, so you're not getting rocked taking call just by yourself, but you need to be intentional to find one of those programs. About 3/4 of your rotation are inpatient, which means longer hours, usually 60 to 80 hours. And when you're on ICU, you're spending 80 hours every week, if not sometimes more. And electives and outpatient are gonna be more chill, closer to 40 or 60 hours per week. I'm hearing conflicting things about whether or not fellowship is actually required. There is a trend towards more and more neurologists doing a fellowship, so now your 4-year training becomes 5 or 6 years. But some are saying that your job prospects are actually better as a general neurologist rather than a subspecialist. The trade-off here is that as a general neurologist, at least in a heavily populated area, you'll see a lot of bread and butter headache and vague neuropathy patients, while more interesting cases get referred to subspecialists. That, coupled with the fact that most neuro fellowships are often only 1 year, they're relatively uncompetitive, provide a compensation boost, and are heavily outpatient focused, there's quite a bit of incentive to subspecialize. Next is the long chart review and patient histories. It makes sense that with neurology, you need to spend a greater proportion of your time on chart review and patient histories, given the nature of the conditions that you're treating and the puzzles that you're trying to solve. In short, it requires a certain kind of patience that I just don't really have. Next is that it's not procedural enough. I never seriously considered neurology because I knew that I wanted to do something that is heavily procedural. It's for this reason that neurosurgery was actually much higher on the list, but I didn't choose that either for these reasons up here. But I was between plastics, ortho, and neurosurge when deciding between surgical subspecialties. Neurosurgery took much of my love of neuroanatomy and neuroscience and applied it in, of course, a highly procedural way. But that's just my opinion, right? Some are gonna say that, hey, there's plenty of procedures in neurology. You have lumbar punctures, or LPs of course, but also nerve blocks, chemodenervation, trigger point injections, EMG, nerve conduction studies, the list goes on. Then there's also lots of interpretation of procedures like TCD, PSG, EEG, including during intraoperative monitoring during neurosurgery procedures, evoked potentials, vestibular testing, and autonomic testing. Most of these things, in my book, just aren't that exciting. I do think you get much more exciting stuff with fellowship training. Things like mechanical thrombectomy via a neuro-IR fellowship, or intrathecal chemo via neuro-oncology, or intraoperative EEG via a neurophys or EEG or epilepsy fellowship. Next, the outcomes. There's a stereotype of diagnose and adios in neurology because many conditions, especially the more serious ones, have minimal treatment options and they tend to be a bit dark. Neurologists will tell you that they can do a lot. Let's say stroke. I mean, sure, you can start with TPA and thrombectomy, but then after that, they can help guide recovery until patients graduate up to PM&R colleagues, and they can help reduce the risk of the next stroke. But overall, the specialty's outcomes and solutions aren't quite the same as other specialties. And if a patient doesn't get to the hospital in time, as they say, time is brain, you can't really do much and the damage is done. You can't actually administer TPA at that point because it's too late, it's outside of the window. Sure, therapies in neurology are a lot better now than, let's say, 20 or 30 years ago when diagnose and adios was much more accurate, but you're still dealing with a lot of dementia and stroke, and you tend to have worse outcomes. And I mean, modern medicine just has a lot of limitations. A lot of conditions have limited treatment options and they can be depressing. Inpatient encounters especially are with very sick or nonverbal patients. And then with outpatient, you're dealing with a lot of people who have chronic diseases. Now granted, this isn't necessarily uncommon for a lot of specialties, but it's also not universal. But don't get me wrong, there's a lot of neuro where you can actually make a huge difference in someone's life. Like you can catch their stroke in time, you can ameliorate their chronic headaches or keep them from having seizures, you can improve spasticity or improve Parkinson's symptoms, the list goes on. And maybe when you can't fix something, you can feel nice knowing that you're there for the patient and their family during a really difficult time. And while you can't cure them, you can at least support them. Next is the lower compensation. Many people, especially in medicine, are too deep on the virtue signaling end of things to admit that they even care about monetary compensation. If you absolutely love a specialty, then sure, you're gonna overlook whatever compensation there is because it provides other value to you. But if you're already lukewarm about a specialty, then a low compensation just turns you off even more from it. Earlier in the video, I had a glass half full kind of mentality. Now let me tell you the glass half empty, which is pay's not great. On average, you'll make a bit more than a hospitalist or psychiatrist as a general neurologist, but unless you go into a fellowship like neuro ICU or endovascular, you'll never really make the GI or cards money, and you really have to work for your money in the higher paying neuro specialties. And finally, should you pursue neurology? I mean, different strokes for different folks. See what I did there? Yeah, I'll see myself out. Look, there are many bad parts with every specialty, and choosing your specialty really comes down to what type of crap are you willing to deal with, and pairing that with whatever excites you enough in the morning to get out of bed. In other words, what has the downsides that you can live with and the upsides that you love? And neuro, it does have quite a few downsides. Many neuro patients have progressive, untreatable diseases, and you will often feel powerless to help them. You also tend to get a lot of patients with vague complaints that don't necessarily line up with a known pathology, as well as many psych patients that can be difficult to work with.
Doesn't hurt.
Also, the majority of neurology is outpatient, so if you don't like clinic, keep that in mind. But there's also a lot to love about the specialty, and for me, the top of that list is really the subject matter and how fascinating neurology and neuroscience really is. Finally, a number of students are deciding between neuro and IM, and here's what I'll have to say. It's all about trade-offs. In IM, you can be a generalist, cool, but keep in mind, you'll rarely work up patients all the way if you're living in a big city. Every time you get an interesting case, they'll be scooped up by a specialist, and if you're inpatient, you'll be managing their chronic medical conditions, blood pressure, sugar, and pain. Want to do an IM subspecialty? Okay, then you'll have to give up the rest of the body and lose your love of generalist medicine. In neurology, you'll also give up the rest of the body, just like an IM specialist. While the two specialties have some similarities, they're different enough that once you get to your rotations, you'll hopefully gravitate toward one or the other. All right, guys, I'm not sure what specialty to prioritize next on Why I Didn't, so let me know with a comment what you want to see. Whatever is the most frequently requested will get priority. Much love, see you there.